Australia. We think by about people in their 70s, about 75% of the population have hypertension, which is defined as a systolic greater than 140 and diastolic greater than 90. And so if that threshold's consistently reached, we recommend blood pressure lowering medication. So blood pressure is really a combination of the cardiac output, which is means how much blood the heart pumps, and how constricted the blood vessels are in your periphery. So the blood pressure is really the combination. Both those factors affect the blood pressure. So if you have a high cardiac output and low resistance, your blood pressure will be up. If you have tight peripheral vessels, your blood pressure will go up. So they're the sort of factors we try and intervene upon to lower people's blood pressure. So as I mentioned, hypertension is defined as greater than 140/90. Low blood pressure is an arbitrary number, but it's not so much the actual level, it's how the patient feels. So we've got lots of patients who have a blood pressure of 100/70, and they feel fine, and you don't do anything. On the other hand, you have some people on blood pressure pills and the blood pressure is 100/70, and they feel tired and washed out, so you back off a bit to let their blood pressure come up. So really the critical thing is 140/90 for people less than 80. Over 80 we relax it a bit and we say it's 150/90. So basically blood pressure is also related to how much fluid's in your system, and we know that if you are fluid overloaded, blood pressure goes up. And so one of the treatments we use for high blood pressure is to remove excess fluid in the system. So that's important in heart failure. It's also important in hypertension. And so if you've got excess fluid, it increases cardiac output, increases blood volume, and increases blood pressure. So the idea is to reverse that and to allow the heart to pump more effectively. So the common blood pressure lowering medications are listed here. Diuretics are basically modified blood volume. They work by encouraging excretion of sodium and water through the kidney, and by doing that it lowers blood volume, tends to lower blood pressure, but it tends to activate what's called the renin-angiotensin system, which we can block with other agents. So that's they're often used. They were the mainstay of treatment of hypertension for many years, and really in the early days we had beta blockers, we had diuretics, and that was about it. Over the last 20 years there's been a whole lot of other drugs developed, which now pretty much have replaced those older drugs, but we still use them to some extent. Now centrally acting agents, again, have pretty much gone out of fashion. They're old drugs, they tend to have more side effects than the more contemporary drugs. The agents we're talking about would be clonidine, which is a central sympathetic blocker, and physiotens or moxonidine, which is a similar one but with less side effects. And again, we use them in patients where we're struggling with high blood pressure control despite using decent doses of the normal medications. We have peripherally acting antiadrenergic, so that's basically alpha blockers, and again they're an old drug. They vasodilate the periphery, good at lowering blood pressure, but one of the issues with them is that they cause postural hypotension. So if you're lying down on one of those and you stand up quickly, it drops your blood pressure and you often get symptoms related to that. So again, we use them, but we use them sparingly, because the other agents we've got are better. Vasodilators we've probably covered. There's various sorts of hydralazine, minoxidil that we use, but again they're 4th, 5th, 6th line drugs, so you probably don't need to know about them. The last three are the most common ones. So angiotensin converting enzyme inhibitors, they are, or ACE inhibitors, are probably the most commonly prescribed blood pressure lowering drug in the world. They work by blocking the conversion of what's called angiotensin 2 to angiotensin 1 to 2. And angiotensin 2 vasoconstricts, and it shuts down the blood flow to the kidneys. and so by blocking it, you you allow the arterioles in the body to become greater diameter, and that lowers the blood pressure. The problem with ACE inhibitors is about 10% of people get a cough, and that can be annoying. So the next class is the angiotensin II blockers, which work the same way but block at the receptor level rather than the hormone conversion level, and they have the same effectiveness but don't have the cough involved. So they're just as good in terms of lowering blood pressure but less side effects. And then we've got the calcium blockers, and they're again very commonly used. They're things like amlodipine, nifedipine, felodipine, and they are very good at lowering blood pressure, but they also produce side effects in some people, which is predominantly ankle swelling, which a lot of, particularly females, get more so than males. It's worse in the summer, and some people get hot flushing and headaches because you get really intense vasodilatation. So we'll talk a bit more about those as we go on. So as I mentioned, ACE inhibitors are very commonly used. They block the conversion of angiotensin 1 to 2, and they stimulate production of a hormone called aldosterone, which also lowers blood pressure. The commonly used ones in Australia be ramipril, they would be perindopril, and they'd be the two common ones. There's a whole lot of others. There's enalapril, captopril, lisinopril, lisinopril, and they all work the same way. But the common ones here would be ramipril and perindopril in the Barwon Health area. They're the drugs we generally use. But the others are good, but they just don't tend to get used as much here. As I mentioned, the only issue with them is about 10% of people get a cough, and if that's annoying enough, then you swap across to an ARB. So they increase cardiac output, they enhance left ventricular heart function by opening up the arteries and making it easier for the heart to pump, and so that affects cardiac contractility and enhances that. So as well as using them for blood pressure, they're really the mainstay of treatment for patients with heart failure who have a weakened left ventricle, a weakened heart muscle, and you use these agents to take the strain off the heart, help it pump more effectively, and it's been shown to reduce symptoms but also reduce mortality or keep people alive when used for heart failure. For hypertension, they certainly lower blood pressure, reduce the incidence of heart failure and heart attack and stroke, but they haven't got proven mortality benefit for when used in hypertension. The side effects is cough's the main one, dizziness, so if you use too large a dose, and particularly if the patient's a bit dehydrated from a diuretic, for example, then they can get lightheaded and get postural dizziness, so you have to be careful about that and back off a bit. The side effects there, impaired taste is an unusual side effect. It tends to be more with captopril than the others, but it is something that has been well documented. Mood changes, I'm not so sure about. The other things we sort of discussed. And it's a result of just lowering the blood pressure too far in general. Now, calcium channel blockers are a different class of drugs, and the way they work is directly on the muscle in the arteriolar wall. So you've got an artery or arteriole. It's like a tube that's surrounded by muscle, and if the muscle contracts, it narrows the lumen, and that puts up blood pressure. So the idea of the calcium blockers, like amlodipine, nifedipine, felodipine, is to relax the muscles in the small blood vessels, open them up, and lower blood pressure. And by doing so, it's really very effective. The other thing that's interesting with these agents is that they have a really pretty straight line dose response curve. With some of the other agents, the higher the dose, you get a plateau effect. So increasing the dose doesn't tend to lower blood pressure any further. Whereas with these agents, it's straight. The higher the dose, the better the blood pressure reduction, but the more likely you are to get side effects. With these agents, the main side effects are peripheral edema or ankle swelling, and it tends, as I said, worse in women, worse in summer, and in some people it's very annoying and you have to stop it. It's because you get vasodilatation, you get an increase in intracapillary pressure, and you get leakage of fluid out into the periphery. Because it's dependent, it tends to be more in the ankles. It can be attenuated by using an ACE or an ARB with it, but it's often an annoying side effect. Other side effects are flushing, because you open up the arterioles, you get more blood flow, particularly to the face, and people don't like that, and similarly headaches. So they're good drugs, but they do tend to have dose-related side effects that some people can't tolerate. Where are we? Now, diuretics, as we mentioned, they basically predominantly remove fluid from the system. So sodium and water is excreted and blood pressure goes down. That's not their only effect, particularly the thiazides. They affect the actual structure of the arteriole themselves, but think of them as diuretics because they do promote loss of sodium and water. Now that's fine for most people, but men who have, say, prostate problems don't like it because they're peeing more frequently, and if anyone has a tendency for urinary frequency anyway, the diuretics are just going to make it a bit worse. They are really pretty good at lowering blood pressure, and were one of the first agents we had to lower blood pressure, and they work particularly well with something like an ACE inhibitor or an ARB, because the ACE inhibitor dilates the vessels and the thiazide diuretic gets rid of fluid, and so in combination they have a really good synergistic effect. So that's a very good, potent combination to lower blood pressure. Calcium blockers you can use them with, but they don't tend to have the same synergistic effect with calcium blockers as with ACE or ARB. The primary site of action is the distal convoluted tubule, and I think we've got a picture of that, haven't we? So basically what they do is work in here, and so what happens, you filter blood into the glomerulus, then blood comes in the afferent arteriole, goes out the efferent arteriole. The pressure in the arterioles forces urine out, and then basically on the transit through the kidney tubule, you reabsorb sodium and water. So the thiazide diuretics work here, and they block the reabsorption of sodium and water, so you lose fluid, you lose sodium, and you lower blood pressure. So there's basically, they are good blood pressure lowering agents, and the higher the dose, the more fluid excretion you get, and more side effects you get. So one of the side effects as well, metabolically, is with these agents, is that because you lose sodium and water, you also lose potassium, and so you often have to have potassium supplementation with these agents to stop the potassium going too low. And you can do that by either using Slow-K or potassium pills to replace the potassium you lose, or you can use an agent we'll talk about in a minute, spironolactone, which works down here to make you resolve potassium. So that combination of a thiazide and a aldosterone blocker work very well together. Dietary sources of potassium: oranges, bananas, orange juice, Coca-Cola have lots of potassium in, but generally it's not enough to replenish the supply. So you often generally need to be on a tablet of potassium when you use these agents to make sure it doesn't go too low. The other diuretics that we use, not so much for hypertension, but certainly in heart failure, are what's called the loop diuretics, and they work here. They're much more potent at getting rid of sodium and water than the thiazides, and the common one we use is a drug called Lasix, and it's called Lasix because it basically lasts 6 hours. And so you take it and you tell the person, stay near a toilet because you're going to be peeing for the next 4 to 6 hours very frequently, and then it wears off. So they're good for moving volume in heart failure. They're not particularly good for hypertension, so they're not often used in that light. They're even more potent at lowering potassium, and so almost certainly with Lasix you have to be on a potassium supplementation. So again,